Thank you. Thank you everyone for joining this session. Thank you all the panelists for being here. This is a topic which is very close to my heart. I've spent last 20 years in the healthcare domain. And over the years, the importance of data has only increased with every single transformation we have seen in the industry. And as we do that, the health stack is the most important foundation. Any insights, any innovation we can do gets only as good as the data that we have with us, right? And the topic of interoperability also has continued to evolve over the years. 15 years ago, when I started my career in health informatics, there was this vision which we heard about having a single identifier and a single longitudinal data of every patient. At least when I started, we thought it was very solvable. In next 2 years, we will solve it. 15 years down the line, I believe it's very complex. It'll take maybe 15 more years to do that. But today we'd like to talk about some of the innovation that is happening. What are the measures that India has made through National Health Stack? What is private sector doing? And what are some of the challenges and advantages of having a common health stack? To begin this journey, I'll like to start this with a question to you, Dr. Sushil. You have been involved in this journey with the Indian government for last many years, like you were mentioning. So maybe if you can take us through the journey, how the conversation has evolved in India over last few years when it comes to interoperability, data standards, and then we would talk about it further.
Yeah, thank you, organizers, to inviting me in such a wonderful event. Last 32 years, I am working in the health IT in AIIMS, New Delhi. There's a lot of activities the government has started. The first activities just started in 2005 that we're supposed to have a standard, health standard in India. And it is started by the Ministry of IT, MET. But that document is in the public domain, you can check it. It is developed by the Apollo, and we are the part of the members of that. But the document is not that much of sufficient that we can make a single medical record for each citizen. The objective was that only. Then 2009, it is taken over by the Ministry of Health. And they have published another EHR. You say EHR they have started. And that was also not that much of sufficient that to make a single medical records. Then it has again revised in 2012, then 12, 13, then 14. Then 14 it has come a full-fledged EHR standards. When it has come about the EHRs, there is a lot of questions. It is that what is EMR, what is EHR, what is PHR? So this nomenclature is a technical nomenclature, it has come up. And it has clearly defined that what is EMR, what is EHR, and what is PHR. Right now, we are in 2014, when the new government has taken over. At that time, they have thought that we have to start something insurance policy to the citizen of India. That is Ayushman Bharat. And for Ayushman Bharat, they thought that how to reimburse will be done very fast and most transparent manner. That's why they have come Ayushman Bharat Digital Mission, ABDM. But in EHS standard, they have started. There is another standard that has come, it is MDDS, metadata and data sets. These two documents, it will create a single medical records in the country. But the question is that who will adopt these standards? And to adopting these standards in different hospitals, they have to invest a lot of money in the applications. And nobody is ready to accept it. Why why the government is unable to force it? Because health is a state domain. If the government of Odisha is not interested to adopt it, the central government decisions, it is allowed. The central government can't do anything. And it is the state government policy that you have to start this, and nobody is ready to accept it. That's why Ayushman Bharat, that scheme, it has not been implemented in Delhi. You see it. Now you must be seen in the newspaper that the Delhi government is not ready to accept this one. It is in the court. It is a state subject. So that's why in between we need a good, robust, single medical record is required. That's why government has started doing Aadhaar ID. It has started during the COVID. Many people, they have COVID, AVDM ID, but they do not know, because when you are getting your ID for the vaccine, COVID vaccine, in that case, automatically ID has been created. Government has done it, but it is it is not an ethical practice, frankly speaking. But you need ID, otherwise you can't do any vaccination there. Some people, they have not done it because it was done between the vaccination time, the first dose and second dose in between. So earlier dose you have taken, it has not been created. Later part, it has been created. So this ID, what is that? In this ID, wherever you go, you can use this ID because your metadata is available to them. And what is the advantage of that? I'm not taking much time now. Yeah. See, why this is, if the Aadhaar ID is created, your unique ID, it is linked to your Aadhaar. So wherever you go, your identity is already, it's matched there, and you can do whatever is transparency maintained, you can maintain it. And what people are doing it, I'm talking about it. जब मैंने एक कंप्यूटर शुरू किया था कि in AIIMS, we get 16,000 patients a day in the OPD per day. The demand is about to be 50,000. Demand supply का इतना gap है, तो सब लोग backdoor method से आएंगे. You got my point? When I have started appointment system, full appointment system, make it transparent. लोगों ने ABC नाम पे आ गए, XYZ में नाम पे आ गए, किसी 35 साल, 38 साल, वो नाम पे वो लोगों ने बेचने लगे. जब डॉक्टर के पास जाओगे, तो वो आपका आईडी वेरीफाई करने की जरूरत नहीं है. That is not allowed also. And Supreme Court also given in this statement कि आप आईडी बेसिस पे किसी को चूज नहीं कर सकते हो. आपको हेल्थ केयर देना ही है. ये एडवांटेज लेने लगे. आज की डेट पे ये चीज है. So health ID, if it is created, it is linked to health records. It will be helpful for you in your life. What kind of treatment you have taken it, you do not know from your birth. What vaccination you have done it, you have taken it, you do not know. But right now, those who are taking the vaccinations, all the records, if it is created the Aadhaar ID, you can access from your mobile. This is the advantage of that. Sometimes you have taken a medicine which it is allergic to you or reactive to you, and it is already been in your health records. You can access the health record from your mobiles. You can show to the doctors, these are the medicines, it is reactive to me. You can prescribe some other salt medicine so that it can be done. So these are the journey the government has done it. Right now the government is working in health information exchange. Already it is there, but it is not full-fledged working. If the health information exchange, it will be created, definitely all the records, it will be in place. But still the challenge is that the authority is unable to force to the private people to adopt the AVDM. So major players in the country, you can say, I don't want to reveal the names, big private hospitals, they are not adopting AVDM, except those who are coming, Ayushman Bharat schemes, they are doing some action, other things not doing. Thank you, and I am hand over to another my friends. Please.
Thank you, Dr. Sushil, for laying the foundation of how entire health interoperability and the basic foundation through Aadhaar ID has evolved in India. If I'm correct, the last count we saw from government was there are 67 crore people who already have a unique identifier. So we have a large population, and this is equivalent of an Aadhaar ID on which health interoperability can be built. But like you said, everyone has to participate for it to be built.
See, yes. The problem is that you have to educate to the people first. Okay, if you educate that what is the health ID, it will help you out, and how to do it, then it will be better for you. Many people do not know it. In AIIMS, what it is that we have started doing patient empowerment. Patient empowerment means if you have a appointment letters, appointments, there is a QR code is available in the different locations. Scan the QR code. Do the registration yourself. It is not required to go to the counter. Okay. After doing the registrations, it will alert it to the doctor and room number. Go there directly. It is not required to any counter to do it. If the AIIMS is not there, it will ask you, do you like to create it? And you should do it. Then the whole process will follow that one. So this sort of thing, if adopted by other hospitals, then it is very easy to create your own AIIMS ID. If the AIIMS ID is created once, and you have forgotten it also, that can be retrievable also.
Correct. I agree. So I want to go to Dr. Rajeev next. We spoke, you have this unique privilege of having worked both in the US healthcare system where a lot of data standards were started around 25 years ago when they started the Meaningful Use Act. And now you have been with Tata 1mg where you are doing the same in India. So if you can maybe help talk about and compare, contrast both these journeys and what you are seeing on the ground.
Sure. Now, I think the precursor to the requirement and the solution that we are looking at India, right, stem from the learning that happened in US. And, you know, it's a journey and a life cycle of how technology and adoption happens. In US, when it started in 1990s, the idea of electronic medical records, electronic health records started, like how any ERP solution would start in an IT world. They started recording all kind of patient complaints and information, diagnostics and diagnosis as well as treatment plans in EMR. Now, once that happened, they realized the importance of standardization because data was getting exchanged in files, but there was no standardization, and that's when, you know, like Dr. Sushil said, the standards came into place, ICD-10 and SNOMED, you know, entire library, LawInc, and all the others. Now, once that happened, there was a sudden realization that there are two systems. They have the storage, they have nomenclature, but they don't talk to each other. That's when HIEs were found, which are healthcare information exchange platforms, which are nothing but kind of like the payment gateways of the country. And that's when HIEs came in. Now, the moment HIEs came in, I was just talking to my friend and Pranshu, and in 2017-16, there were 62 HIEs only in California, which meant there was a mishmash of data flow from EMRs. There were a couple of thousands of EMRs, there were a couple of hundreds of HIEs across the country. And then what was really happening was that the economic value that was getting lost per longitudinal health record, what we are trying to achieve in India, was north of $2,000 per year. Now, if you can imagine, if there are 150, 200 million health records in the country in US, multiplied by $2,000 a year, India cannot afford that kind of healthcare expense just by losing the value that could have been created by digitization. So I think that's the entire journey. Now, I think India really leapfrogged and came out with this one national health stack and the protocols, which is fantastic, you know, in terms of idea. And as Dr. Sushil said, now of course we are seeing the teething issues and incentive issues of private industry as well as government, you know, the way we are structured, state and central health in, regulators, that we are trying to put them into some sort of synergy. But I think this is the right way. We've already taken the first right step by standardizing, giving one protocol. Now, in terms of adoption, just to add from a private point of view, I totally agree. I think right now there is not strong enough incentive as well as, you know, like a regulator push in a centralized or a statewide way that could push adoption. And see, we have to understand many of the doctors, independently practicing doctors, are still, the good ones are probably above 50, 55 years of age, where they had no technology tool when they were studying and, when they started practicing. Maybe the age group of 40 and below is probably one. And it does not mean that doctors are bad at learning, but I think it's just the way they've been taught. I would actually assume if there is a tab-based or phone-based EMR system, I think the adoption is far better with doctors, because doctors never use laptop, people who are above 40, but they directly went to the touch screen. So they're probably better at touch screens than typing. So I think those are some nuances which are now helping adoption. I think another 4 or 5 years, we should see what we aim to achieve by digitization and standardization of healthcare data for all kinds of utility and usage.
Got it. Well, thanks. I'll come back to you. I wanted to ask a couple of tactical questions around what you are doing around this. But before that, I want to come to Pranshu. Pranshu, you come from Paytm. So unlike the three of us, you don't have this 20 years, 30 years of healthcare baggage. You look at the world digital first. Right. Also on the insurance side, so at the end of the day, you are the one who can create an incentive for everyone else. So what has been your experience looking at healthcare data at Paytm? How do you try to derive value out of it?
So I'll give two perspectives. The Paytm perspective, and way back I was working for an insurer, Sahi, a standalone health insurer, where I was leading data science as well. So firstly, from the insurer perspective, right? So the goal of any insurer is to, be able to price different customer cohorts correctly, right? So being able to understand, you're paying me a subscription. The subscription amount should be a function of your probability of getting hospitalized. The better it is, the fairer it is for everyone else. The second thing is obviously that when you go to a hospital, the whole process of claims adjudication, where a TPA takes your documents, uploads it into this thing, and then there's a set of doctors that are at our end who are figuring out whether to pay the claim, not pay the claim, how much to pay, was this cost justified, and then also solving for frauds that happen or sort of wastage that happens at hospitals because you've got insurance and the bill is inflated. So from that sense, number one priority is for me to be able to underwrite if I can know your prior medical records. And at the time of claim adjudication, if I can know what happened, what was the procedure, if the procedures are codified, the entire processing of it becomes instant, right? Because a rule engine or an AI model can very easily predict or tell you what to do. And that brings down the entire cost of premiums as well, right? So from that context, a lot of work was being done to be able to get data. But as we know, the data is very fragmented. The norms were different. There's a lot of gaps in data, a lot of different kinds of diseases. While there are ICD codes, most of them were fever of unknown origin, right? And also there are many legs in which who's filling up data, the TPA is filling up data somewhere. A lot of fields are not available. And all of that makes building a model on top of it harder, right? So step one for any model or data model or AI model is to get data in a standard format, fill it up for all customers. And also it should be available holistically for all customers, right? Because if some customers have more data, some customers have less data, the model obviously will have skews in itself, right? So theoretically, if all hospitals start putting in data, insurance obviously does act potentially as a hook or an incentive, and that can be made mandated or pushed there. It is obviously not going to have, there are other problems that Sir pointed out from hospital perspective, but that is the sort of the end goal of what this can do. And if this happens, the whole process of insurance becomes far more seamless. The costs come down, the wastage come down, and a lot of preventive stuff can be done, right? Because I'd rather not have you go to the hospital at all, especially in case of chronic customers, especially in case of potentially preventive wellness add-ons that you already have in insurance. So that is the insurer sort of perspective. From a Paytm lens, right? So now the idea for us has always been that why do you need the entire stack of humans sharing, say, cash today, replaced by a phone, replaced by a QR, right? Can the entire experience of consuming healthcare also become that seamless at some point, right? At the end of it, there's always going to be the human element, but at least the rest of it can be streamlined, right? So the right procedure to the right customer, a lot of tertiary care converting into primary care, because a lot of this happens by the time you're at that stage, you have to get hospitalized. but a lot of the initial this thing could have been read faster, having panels of doctors. And what we're also trying to do is, at different places, we're trying to stitch all of this together. So we have the Aadhaar ID enrollment. There's been a huge amount of Aadhaar ID enrollment on our app, especially during the peak at COVID. A lot of the storage of your vaccination certificates at various places, the insurance business that I deal with, adding OPD elements, preventive, doc on call, all of that. So how do you stitch all of this on a data layer to be able to make it more seamless for anyone and everyone, and also make it pan-India, which is the other problem. This is possible to do much easier in tier 1 cities, but the problem is more prevalent in tier 3. If that is digitized, the cost of administering healthcare and the right healthcare and making sure allergies are not there and so on is simplified far more. And theoretically, a private-public sort of integration and a lot of different companies
So
will
one
help.
follow-on question on that, right? As an insurer, you have a unique lever to incentivize this, and I've seen insurance companies try to incentivize preventive care. How successful have you been? How much adoption have you seen when you try to put an incentive for preventive care?
Okay, so I'll talk about the insurer that I was part of. This is in 2015-16. We had a preventive wellness option. That is, you walk X steps and you can get 30% of your premium back, and you had points. And the other angle was chronic management, right? So specifically people with diabetes, asthma, etc., had preventive wellness built into it. So you have free checkups, you can talk to a doctor, you have a dietitian appointment. What we distinctly saw is that it is a cohort level thing, right? So the diabetics had far higher adoption, right? Because they're used to it. But the other segment where if the person is young, right, you don't believe you'll fall ill. So you don't want to, you might have thought of it while buying the policy, but almost 1 month down the line, you forget about it because there are 20 other things in your life that you're focused on, right? And again, there are like thousands of apps that help you do all bits and pieces of healthcare. So adoption has been a problem. And I think it also needs extra push from the insurer side to get people in, because again, the mathematical thesis is that if my claim severity goes down, effectively it's better for everyone, right? So that is why we keep pushing for it, but it's hard to do on certain cohorts.
I agree. It's still difficult, right? Like theoretically, all of us get it, but it's hard to put it in practice. Rajeev, I wanted to ask you also, at 1MG also, you guys do a lot of preventive health. 2 questions on that, right? One is, from preventive to curative, what has been your experience integrating with the national health stack? Second, as a private organization, when users entrust you with data, you're supposed to share some with the national health stack. In general, how do you manage that data governance, data security aspect? Because that also could start becoming a concern for healthcare data.
Yeah, I think I'll take the second question first, and you touched on just the right point. I think security of data, especially, we know, I think last year or last to last year at AIIMS also we had that malware attack, and it's becoming of high importance in terms of, because the more the data will flow from one server to another, the more the leakage chances there are. So I think it's very important and to ensure the security of data at not just one node but multiple nodes where the data is being fetched or or pushed to. So there's no question there, and I think what I personally feel is it's not just about the security of the data in healthcare, but I really feel the way we are going digital, and we touched upon diabetes. Let's say, we've got our CGM or continuous glucose monitor, and we also have, that the data from there is going continuously to your app. Now you also have insulin pumps, which also calculate your insulin based on your glucose and then pump accordingly. Now imagine if this entire digital feedback loop gets hacked for entire day. These are lethal consequences. Now, so I feel more than just the security of the data, I think the continuity of data is even more important in healthcare, especially as, if I talk in Indian context, we are generally, even if somebody asks for Aadhaar, we just push it. So we are not that difficult when it comes to parting away with our data. But I think the continuity of healthcare, where technologies like maybe blockchain, where you could have multiple nodes and all of those things, these new age technologies, or maybe multiple layers of encryptions and multiple copies, or like in IT, sir would know better, homomorphic encryption and all kind of things. I think those are really needed before we go one step over this foundation of exchanging data, and I think government is working on it. There are enough guidelines and advices from the government in terms of data security as well, so IT security. So that's number two. Number one, I think in terms of private adoption and how we are looking at it, we are at so there are 3 levels of integration. We are at M1 and M2 right now. We haven't really started interacting with data. We haven't really opened that gateway
For
today.
the audience, can you explain what is
Yeah.
M1 and M2?
So ABDM, M1 is effectively, just to make it very, very simple, is creating your ID. M2 is pulling data, and M3 is pushing data, or one of them. So now, before you could do the creation of ID and then do the pull and the push of data to other servers or other parties, but now the NHA has made it compulsory to do all 3 and get the functional testing done before you can really start getting integrated with ABDM and exchange data with other parties. So that's where we are. At Tata 1mg and generally in the private sector, I think the advantage of, and I'll use the recent terms that has come out with DPDP, the data fiduciary platforms. So I think these big platforms right now don't see that incentive to connect with all the rest. Although there are startups and others who, in an anonymous way, one could share data with for giving recommendations, providing better support, better cure, better prevention or preventative health. So those are things I think in the private space that could really take off between the healthcare startup space. And sir covered, or in terms of what is happening with the hospitals, I think there is certain bit of resistance or slowness, I would say. Probably people are adopting, but they are slow. So that's where we are, in terms of private adoption.
Got it. So I want to come back to you. In terms of, we were talking outside also about healthcare interoperability. Actually, a lot of standards, like you said, already exist. It's about awareness and willingness to adopt those standards. So if you can share what all healthcare standards exist at an India level, which either global, which we are using, and where are we in terms of that adoption journey, whether it is for ICD codes or any other standards?
Yeah. Healthcare standard is a very complex, very, very complex. And healthcare domain itself is a very complex. You must have seen the movie Munna Bhai MBBS. What he has spoken. The patient need immediate medical intervention, but it is a medical legal case. It cannot be taken before police has to come and take the record of that. So when police will come, patient will die. This is the situation. Still it is there. Okay. Similarly, in health records, when you go for a digitizations, there is a lot of standards are there. I've already told you that electronic health records, one standard is there. There it is mentioned that your demographic details, it will come from the Aadhaar. Your, let's take, your lab reports, it will be in the LOING. Your medical imaging, it is from DICOM standards. Your clinical information, it's supposed to be SNOMED City. Your health record securities, it will come to the ISO 27000, something is there. So a lot of standards are there. It is mentioned in the EMR standard. All the listed it is giving, it is published in 2014. And it is a public domain. It is. If anybody is interested, you can download it, you can study it. All the given is around 33 different standards it has been mentioned. I mean, ICD codes are also there. So you have to adopt all the standards because you have to train to your doctor also to adopt this when they are making the records in digital records. And doctors are not trained. Nowhere in the MBBS level or MD levels also, there is no such type of courses is available to them to award it. But in AIIMS, we have already started it. Another is nursing informatics also. It is there. Nursing clinical record standards also, it is there. So a lot of things are there which if you will incorporate, then that record will be interoperable. Means your record can move. And right now, any digital transformations, all are database. All are data-driven. And if data is available, there's a pros and cons are there. 2009, Barack Obama, when he has taken the oath, at that time he has spoken, he want to make a single medical record for all Americans. Till date, it has not been happened. Because they have also same problems that each state has own rule and regulations. The regulatory is different. In India also it is same. But when the Ayushman Bharat Digital Mission has come up, it has given a new light to us that data can be some extent interoperable. And patient empowerment it is given to them. How it is? The problems which has come in the US during the Barack Obama time, that things they have taken care of that. When the patient is admitted, which doctor is treating, which hospital is treating, who are the stakeholders it is involved, all these things it is not taken care by the Americans. But in ABDMs it has taken. So those who are doctors, it has to come to the ABDMs, doctor's ID will be there. Means patient ID is there, doctor's ID is there. Means this doctor is treating this patient. And these are the clinical outcomes. Means there is a transparency is maintained there. If the nurse is giving the treatments, nursing ID also it is there, and that ID is come from the nursing registration form. If somebody is giving to you that physiotherapy, that is also part of the treatment plan. So physiotherapy ID is supposed to be there, that this kind of physiotherapy is given by this physiotherapist. Means all the IDs are available. Let's take, you have taken a test in the Dr. Path Labs, showing in the max. Okay, though the two different records are there. Path Labs, they have your records, and here they have records. You are downloading it, you're showing to the doctor is writing it. But this report is available in two places. That's why government has come ABDMs. Both the records can be accessible by the patient. You can download the apps, and you have a ABHA ID. This ABHA ID is attached to the Dr. Path Labs and the hospital you are treating there. So you can link it. So all the records, it can be accessible from your mobiles through ABDMs if you have registered it. This is one of the plus points it is there. Because all the standards, all the hospital has to be adopted. It is a very difficult task and very cumbersome. That's why government has started in 2017 that I need this and this kind of things done as early as possible. And that's why it is implemented. And really, frankly speaking, because during my journey, I have said this is one of the best steps government has taken it. But what is the problems? This is the advantage for you, your health record is in your mobile. All the tests which is you want, we have done it, that is in your mobile, you can access it. But what is the problems? Do you know, if a hacker is interested to hack a bank account somebody's in US, right now $3 to $10 they charge. If you talk somebody's health record, it is $300 to $3,000. Why? There is some reason is there. If your health record is gone to the insurance people, let's take you are in the near to the boundary of your diabetes. You are in the boundary levels. This information has gone to the insurance. Insurance will tell, no, whatever you take any insurance policy, it will go up. It will go somewhere for a job. They can assess your records. You are suffering this disease, I can't take it. These are the major demerits, what it is there. That's why in US, for the public safety, because they want to link to the social security number of US. And strong protest has come from the publics. That's why it is not been implemented. In India, it was not there, and they have taken many few steps. Each service provider has a ID. AIIMS is giving the service to the patients, AIIMS has a ID. Dr. Path is giving a service, Dr. Path Lab has a ID. The person which within the hospitals in AIIMS, the doctors all has the doctors Ava ID, patient Ava ID, service provider Ava ID. All are unique, and a lot of transparency is there. This is one of the good thing is there. Bad thing is that lot of, because today's days you must have seen in the news that you're supposed to have protect your own personal records. This personal record is somebody else and it is vulnerable to it. If it is gone to the somebody else, in that cases you are in trouble. Even you will not get the loan. If you've taken the loan for the house for 15 years or 20 years, they will see you have this disease, your lifespan is this, I will not give the loan to you. This is the disadvantage of that. So we have to take a call on it, whether we choose this or this. Thank you.
Thank you so much for sharing, sir. This is a topic which I know all of us are very passionate about and can talk endlessly, but probably in the interest of time, we'll take a couple of audience questions, if there are any. Yes, please.
So, I have a question like, see, from the adoption perspective, right, we see the Essential Medicine Act, which is there in the US, but here in India, the scenario is very different. When we talk about the, obviously the metro cities, scenario is different as compared to the tier 2, tier 3 cities, right? From now, if we see the acute segments where the physicians and other doctors who are there, not the chronic disease segments, the actually patient to doctor time is very less, which is like 2 minutes per patient maybe. And less than that. Less than that, yeah. So in that scenario, we are all talking about digitization of healthcare, but a doctor doesn't have a time to record whatever he's scribbling on a paper. He can't replicate the same over the systems which the complex systems which we are creating. That's a very easy thing to say, but very, very difficult to actually execute the same. I don't know how other hospitals are doing it, but I have actually seen in tier 2, tier 3 cities when we take views of doctors, they say, please, EHR or EMRs are not meant for us, at least for doctors who are like who are from the acute therapies perspective.
Yeah. I have to take that one?
Yeah. No, sir, you see the maximum number of patients at AIIMS, so you should take it.
Yeah. One live example I'm giving to you. We have started paperless in gastroenterology. Okay. Within the gastroenterology, we have 7-8 different specialized sub-departments. पेंस्क्रिया के लिए एक है, IBD के लिए एक है, आपका जो ICU for the gastroenterology patient is different, liver के लिए different है, and because see, AIIMS is a institute for the what? Sorry? AIIMS is an institute for what? This is a question to you. No. AIIMS is an institute for the health research. First objective. Then education. For these two, it is required a healthcare setup. You got my point? So, research means you need data. Without data, you can't do the research. Means you have to capture the maximum data, then you can get a maximum research output. We say more data, more healthcare. Less data, less healthcare. अगर डॉक्टर के पास आपका इंफॉर्मेशन नहीं है, तो he can't take a right decisions. You got my point? Now we come to your questions. When we have started the gastroenterology department for the paperless, each records for the new patient is taking 35 minutes. 35 minutes to record each and every thing. It is just impossible for us to do it. And it is failed. It is failed. Okay. But when the record is already entered, the record is there. Let's say you have a chronic disease for last 10 years. When you go to a doctor, he is not remembered you. Okay, what did happen? He has to read everything. And it is a 50 or 60 page. How will you read it? If it is electronic records, it can mention, okay, he has a diabetics, he has this. And this is the current treatment. So it will take 2 minutes, even not 2 minutes, 1 minute, it will help you out to do it. If you have an AI agent, it will take half minute. AI agent will suggest this kind of treatments, and you have to validate it. That's all. But when you are talking about that, it is not possible. It is possible right now because voice to the text, it has come up. And the voice text is integrated with medical terminology library. Okay, let's take, we have to fill this performa. Okay, next steps. Okay, move to this field. Then call a particular word, the terms. That terms it will fetch immediately there. Or if you drop downs, automatically from drop down it will be fetching. So it is going very faster. But thing is that you have to invest the money for it. There's a cost to associate with it. The cost will go down because many open source software free of cost it is available, and more than 98% voice to the text it is converting. This is one of the things it can be done. But third thing is before that, the application supposed to be available to them. That is cost to you. Maintaining a hardware and the cyber security, it is a big challenge. Do you know, after cyber attack from AIIMS, now we need a budget of 350 crores to protect whole AIIMS. But if you see other states, whole state is spending 100, not even 100 crores for cyber security. But only AIIMS is needed 350 crores. It is just impossible to government sanction the money. We are struggling for last 2 years. And we are not getting the money because otherwise it is not possible. So there is a lot of things. Another thing I'm giving to you for you. Now DPDP has come up. Okay, you are aware of that, and most probably next month, someday it is the last day for the public opinions. Before that, in 2016, there is another act that has come for the public domain for the opinion. That is DISHA. Digital Health Records Security Systems. That has still it has not been approved because they are waiting for the DPDP. Now DPDP has come up. After DPDP, it will go to the DISHA, and DISHA will be again modified, and that will come up. But thing is that you are very much right that those people who are OPDs seeing a lot of patients, is very difficult to put the whole clinical records. The first time entering is very cumbersome, but second time visit, it will go down definitely. That culture has to be developed, and the technology is supposed to be in place. Because they are writing there. Okay, and when you go to the systems, so it should not take much time because voice to the text. I hope you got my point, yeah.
Thank you.
Thank you, sir. There might be more questions, but I'm getting the look from the organizers. So what we'll do is, with this, we would conclude this session. I thank all the speakers, all the audience for attending. We'll hang around outside for some time if anyone has any questions for the speakers offline. But thank you, everyone. Thank you for the